every Saturday, 9 to 10 a.m. India time, where one of the students like you presents a case which is discussed by faculty, including me. Sometimes the students prepare and present an operative surgery session, indications, preparation, contraindications, procedure, and complications, which again is moderated by faculty. Once in a month, every last Wednesday and Thursday of the month, 7 p.m. to 9 p.m. India time, we have a master class where we cover a single topic with a panel of about 6 to 8 to 10 experts and moderated by another faculty colleague. This is the 18th master class in the series. Once a year, we conduct an annual continuing medical education program, which we call Jaipur Surgical Festival. So 4 JSFs have already been conducted. The 5th one will be held in December, 5, 6, and 7 December. The theme will be surgical, radiological, and endoscopic anatomy. All the academic activities of JST, the master classes, and JSF get technical support from the team, including Pinesh and Hemanshi, from my former fellow and consultant GI surgeon in Ahmedabad, Dr. Avinash Tank of Dwarika Clinic. And this team then records and uploads all the videos on the Gastro University YouTube channel. So if you put Gastro University in the YouTube search, it will take you to all the videos. So all the more than 200 videos of JST classes, all the 18 master classes held so far, and the proceedings of all the 4 Jaipur surgical festivals are available for complimentary viewing to all the students on the Gastro University masterclass. For this particular masterclass, I'm not able to let you see me because I'm actually sitting at the airport on my way back from Kathmandu to Jaipur. And for the same reason, I may not be able to join you through the entire masterclass. And I'm very thankful to senior colleague, Dr. ANGELINE Radjou, who was the professor of surgery at the Pondicherry Institute of Medical Sciences and an expert on trauma, who very readily volunteered and agreed to my request to moderate this masterclass on abdominal trauma. So with that brief introduction of JST, masterclass, and JSF, I would hand over the masterclass to Dr. Angelina to proceed further with the activities. And I would also like to thank all the panelists which Dr. Angelina has kind of made the program. And I would like to personally thank them. If possible, I will join at the end of the masterclass again and thank everyone. Otherwise, I may not be able to address you at the end. Over to you, Dr. Angelina.
So thank you very much. And I welcome all the panelists. And at the outset, thank you very much, Dr. Avinash and Mr. Pinesh, for giving us the technical support. We have 4 presentations lined up, and there's a slight change in the schedule. The one on interventional radiology and abdominal trauma by Dr. Shivanand has been scheduled to the first position because he has some professional work, so he has requested. We will start off with the first presentation, which is the role of interventional radiology in managing abdominal trauma. And Dr. Shivanand is the professor of interventional radiology at AIIMS, New Delhi. He has more than 100 publications, and he has given multiple orations and received multiple awards. Thank you so much, Dr. Shivanand, for accepting our request, and over to you.
Thank you, madam. Thank you. Good evening, everyone. I will start.
I will interrupt for a second, Shiva. I must add that Shiva is one of the leading GI and HPB interventional radiologists of the country. So I'm very happy that Shiva agreed to be a panelist on this.
Thank you so much, sir. Thank you so much, sir. So, madam, hope you are able to see my slides.
Yes, yes, Dr. Shivanand.
Okay, okay. So this mainly the masterclass or a talk is, I will cover up the what are the scenarios we can offer this facility in treatment of the abdominal trauma. So I'll start with the case scenario. This is a 33-year-old female encountered a road traffic injury at presentation to our trauma center Her BP was 90/60. She was having a tachycardia. As per the ATLS protocol, the fluid resuscitation was started. And this was the initial X-ray that showed a open book APC3 type of fracture. There is a widening of the SI joint. There is a pubic diastasis. If you see here, there is a bony spike from the sacrum, which is displaced and lying to the left of the hemipelvis. So after the fluid resuscitation, her BP was measuring 100/70, but the BP was a highly variable. Tachycardia was persistent, and labeled it as a transient responder. So at this juncture, we discussed whether this patient should go to operation theater or we have time to go ahead with a angioembolization and deal with by an intervention method. So as per the discussion, we decided to go ahead with a DSA. So this is immediately we under ultrasound guidance we got access to the transfemoral route and reached the left interiliac artery that showed that there is a complete rupture of the left interiliac artery with extravasation of the contrast, which was leaking into the pelvis. So immediately what we did, we put a embolization coils in the common interiliac artery, and hemostasis was immediately achieved. And later, the definitive treatment for the pelvic fracture was planned. So that is one case scenario. So coming to the case scenario 2, the 26-year-old male with a blunt trauma abdomen, hemodynamically stable, presented to our trauma center. So in any blunt trauma abdomen, the further imaging, it depends upon whether patient is stable or unstable. If the patient is unstable, even though in the treatment bay, the following things are done, like we do a fast chest X-ray and a pelvic X-ray. That will give you a lot of idea what is the area of the probable source of bleed. If the unstable patient this patient found to have a fast positive, that patient will go directly to the OT. However, in our case, the patient was stable. The fast and chest X-ray, pelvic X-ray were done. Fast was positive. So in stable patient, so in order to identify the source of the bleed inside the peritoneal cavity, so usually these patients undergo the contrast enhanced CT scan. So in our case, the fast revealed a fluid in the abdomen. That means there is a hemoperitoneum. So we have these three options: CCT abdomen, DSA, and OT. So in our case, because patient was stable, so we decided to go ahead with a CCT abdomen. However, if the patient was unstable, then he or she will go to OT without wasting time in getting a CT done. So, but our patient was stable, we decided to do a CT abdomen with contrast. When we call it as a CT abdomen, it is not only abdomen, it is a torso CT. We do both thorax as well as abdomen because there are multiple associated injury. We don't only do only CT abdomen. So in the index case, what it showed, there's extensive areas of contusions, lacerations involving almost all the segments of the right lobe. And there is if you see here in the segment 8, there is a focal area of contrast blob, okay, within the contused segment. So that means if you see this kind of a contrast blob within the contused segment, that means it suggests an active extravasation of the contrast. That indirectly means the patient is actively bleeding. So actively bleeding patient, however, he is stable. So if the patient is stable and it is active bleeding, that patient will be at our center. We subject that patient to DSA followed by embolization. If the patient after the CT, he or she becomes unstable, he will go to OT without wasting a time. So in our case, we decided to take up this patient for angioembolization. So immediately when we cannulated the right hepatic artery, confirms the finding of extravasation of the contrast from the right hepatic artery anterior division. We reached that area selectively and put a coil, and hemostasis was achieved. completely. This is a post-embolization angiogram that shows complete cutoff of the blood supply that was actively bleeding. So what we learned? We learned the extravasation of the contrast on CT that suggests it's the active bleeding. It needs some kind of attention, either operative method or endovascular method. So in such cases, if you have all the facilities, technical expertise, and you can mobilize your intervention radiologist, nothing like angioembolization. So angioembolization plays an important key role in controlling bleeding, provided patient is stable in to shift the patient to IR room. So uncontrolled bleeding is a major factor that everyone knows in setting up trauma, which accounts for 30 to 40% of the trauma-related deaths. And the management is always interdisciplinary. And at our center, IR is an integral part of our trauma team. We actively take part in decision making. But having said that, first important thing is to stabilize the patient, identify the source of bleed. Don't waste your time, because time is a critical. So now in a brief view, what are the areas we contribute to IR in abdominal trauma? Most of the thing it is therapeutic, like wherever there is a vascular injury in the form of extravasation, pseudoaneurysm, or AV fistula, that is a commonest indication in our setup. Sometimes in the hemostasis at anatomically stringent sites, like in our first case, pelvic fracture bleeds. If the patient is transient responder or stable patient, and you demonstrate an active extravasation like patient or contrast on CT, in such cases again we do an angioembolization. Third scenario is rebleeding after packing. So usually the unstable patients are usually if the past is positive, they are usually taken up for a OT. If there is any hepatic injury or a splenic injury, the hepatic injury especially, they do a perihepatic packing. Even after perihepatic packing, if the patient continue to bleed, they are usually shifted to our IR lab. We do an angioembolization, because uncontrolled bleeding even after packing, that suggests there is underlying arterial source of bleed. And one controversial indication is the prophylactic embolization. But in a high-grade liver and a splenic injury, without vascular injuries, we do, especially the splenic injury, we do prophylactic embolization in order to enhance the success of the non-operative management. So I will show these scenarios one by one. So main intention of the embolization is to reduce the perfusion pressure. By putting embolizing agent, we go as close as possible to the site of bleed. So as I said, time is a money. So we don't waste time in shifting this patient and reaching the source of bleed. So you have to treat this bleeding before coagulopathy, metabolic acidosis sets in. If the patient develops any of these coagulopathy or metabolic acidosis, you do whatever, the bleeding will not be controlled. So hence, you have to mobilize your IR team as early as possible once you identify the source of bleed. So we use we usually commonest route is the transfemoral route. We use a diagnostic catheters. Because the arteries which are actively bleeding, they are very in a spastic state. We use a microcatheter. These are about 2.5 to 2.7 French catheters. These are various microcatheters. Once we reach the site of bleed, we use either gel foam, coil, or a glue. So depending upon the situation, the commonest embolizing agent which is used in a trauma setup is the coil. Maybe we add gel foam, top it up it. But if the patient is having a coagulopathy, in such cases, this coil and gel foam won't work. In such cases, we use a glue. There's no role for a PVA particles in trauma setting. So as I said, we use combination of coil and the gel foam commonly to embolize these arteries. Let us see some specific situations. These are liver injuries. This is one case. This is a splenic injury, which is extravasation, where the bleeding is happening from parenchyma to the peritoneal cavity. This is a pseudoaneurysm, where it is a contained leak. The vascular injury is contained, within the parenchyma, and there is a perisplenic hematoma. But in this case, the bleeding is free, which is actually bleeding from the surface into the peritoneal cavity. These are the two most common indications in the for the IR treatment. So in this case, this patient had a gunshot wound. There is a pellet is lying in the subcutaneous plane. There is a large perisplenic perihepatic hematoma. This is a pseudoaneurysm. This is the right replaced hepatic artery. This pseudoaneurysm was arising from the anterior division of the right hepatic artery. We selectively reached that and embolized it. So this is another case. If you see here, there's a large area of contusion within the hepatic parenchyma, and it was actively bleeding the extravasation of the contrast into that contused segment. Again, we did angioembolization, reach that artery and put a coil and sparing rest of the liver parenchyma. If you see here, beautifully left hepatic artery, posterior division of the right hepatic artery, all are spared. Only we selectively embolize the bleeding artery. So now coming to this is another situation, bleeding after surgical packing. If you see here, these are surgical packs over the perihepatic area. This patient was actually bleeding even after surgical packing. Our lab is very, very close to our OT. He was immediately shifted. When we took an angiogram that shows multiple areas of active bleed, we selectively embolized both of these active bleeds by using the embolization coils. This is, if you see here, this is a patient who had active bleeding, but immediately after the CT, the patient became unstable. They took this patient for OT. They did a packing. Even after packing, this patient was actively bleeding. If you see here, so we took an angiogram. This was actively bleeding into the peritoneal cavity. Again, we did a embolization using coil plus gel foam. So sometimes these patients, when we do a non-operative management, these patients go home and come later with a hemophilia. So this was a child who was treated with a non-operative management, had a hepatic injury, but later he presented with hemophilia and did a CT that shows a well-defined pseudoaneurysm with a partially thrombosed, and we did a DS and confirmed it as a Doppler. We took this patient for angioembolization, and that we successfully embolized it. But later again, this patient, after 2 days, when we did a check angiogram before the discharge, that shows a recanalization. So we have already embolized this patient. So we lost access. Then we did a percutaneously puncture of the pseudoaneurysm, and a leftover pseudoaneurysm was embolized using glue. So that was the final picture. We took a check angiogram so that no longer this pseudoaneurysm was filling. These are the glue cast. So this is the final ultrasound picture before the discharge. The pseudoaneurysm was completely thrombosed. Now coming to the splenic injury, apart from vascular injury like liver, extravasation, pseudoaneurysm, we do what we call it as a prophylactic embolization. This is just first finish extravasation. This is an active extravasation confirmed, and we did an embolization using a coil. However, this patient has a high grade 4 splenic injury, no extravasation, but in order to enhance the non-operative management, we do a prophylactic proximal coil embolization. We put a coil in between the dorsal pancreatic artery and the pancreatic arteria magna, in between this, so that you are reducing the perfusion pressure, and the collateral circulation in the distal splenic parenchyma is still maintained. But by reducing the perfusion pressure, you are enhancing the healing of this injury. So that is the role of so just short of splenectomy, you can treat this high-grade splenic injury by doing a prophylactic embolization. This is a focal vascular injury arising from the upper pole of the spleen. So we went distally close to the site of bleed and did an embolization. This is called as a distal embolization. Okay. Similarly, the renal arteries are managed by putting a coil, the typically pseudoaneurysms or extravasations, just like a splenic or liver, we do an embolization. This was a right kidney was completely shattered. There was active bleed from the lower polar artery, which was embolized. This was a pancreatic injury with a pseudoaneurysm. If you see here, there's a contrast blob and there's a large hematoma. There's a through and through laceration of the pancreatic head region. This was a child. So this was arising from the GDS stump. So because there was no adequate landing zone, we filled the entire sac of the pseudoaneurysm using glue cast and sparing rest of the liver parenchyma and the rest of the hepatic artery. This is an unusual case where there was a pancreatic injury, there was a large devascularization of the right kidney, there's a large aneurysm. This aneurysm was not arising from the artery, this was arising from the SMV. So what we did, through the transhepatic, we punctured the portal vein through the transhepatic route, reached the site of the pseudoaneurysm, we crossed across the pseudoaneurysm, reached the SMV, we reconstructed the SMV using a stent graft. If you see here, this is a pseudoaneurysm. We put a stent graft isolating the pseudoaneurysm by using a stent graft, and percutaneously the tract of the liver was embolized using gel foam. Usually the mesenteric injuries are usually associated with bowel injuries. They are usually managed surgically, but there are situations where mesenteric injuries, they present late with a pseudoaneurysm. This was one of these cases. This patient was managed somewhere, mesenteric injury, but later he presented to our center with melena. When did the CT that shows a pseudoaneurysm from the one of the mesenteric artery. So we took this patient. This was patient having a melena. Then we did a DSA that shows the pseudoaneurysm arising from the jejunal branch of the SMA. We selectively reached that area and embolized it. So that is how mesenteric injury is not a case for IR, but if their patient is presents late with only a vascular complication, that can be selectively managed. This is our last 10 years data. We did around 1,100 cases comprising various cases. And so we also, apart from vascular, we also contribute to do biliary and urinary leaks. This patient had a CBD transection. We did a biliary diversion. So later this patient was managed by hepaticojejunostomy. This patient had an active leak from the CBD. Similarly, whenever we have a ureteric transection, usually the ureteric injury, the PCS injuries are managed conservatively or by digestant. But some cases where there is a ureteric transection, in such cases we do a urinary diversion so that later these patients can be managed definitive treatment. So in conclusion, so there is a paradigm shift in the management of traumatic injuries with a trend towards non-operative management. In such cases, the IR is an integral part of the non-operative management to provide initial hemostasis. And this has helped not only reducing the mortality, but also it enhances the faster recovery. Thank you so much. I'll be happy to take up any questions if there are.
Thank you so much, Dr. Shivanand. That was very enlightening. I just want one question I have. What about external iliac artery injuries in the setting of pelvis fractures?
So, madam, majority these patients are very unstable. They are usually go to the OT. If you have mainly like AV fistulas or a contained leak like a pseudoaneurysm, so if you are not actively bleeding, then which can be managed by putting a stent graft. But if the patients are, if there's active bleeding, if the patient is unstable, obviously that patient will go to surgery.
Okay. Then regarding chyluria, leaks.
Leaks, madam, I did not show that. We have a few cases of chylothorax.
Okay.
So either we go through two routes. One is we initially evaluate the site of leak by MR lymphangiography. Once we get to know the site of leak, we either go through the trans-abdominal cisterna chyla puncture. Then through that we pass a guide wire and embolize it, or we go a retrograde route through the at the junction of the IGV and the subclavian vein, retrogradely where the thoracic duct drains. Retrogradely we cannulate and reach to the site of bleed. But the best route will be through the the cisterna chyli route. In a desperate situation, if you are not able to, because actively leaking chyles, the cisterna chyli usually collapsed. It is very, very challenging to puncture the cisterna chyli. But we have done few cases by retrograde route as well as antegrade route.
Thank you, Dr. Shivanand. Any questions from the audience? Please ask. That was really good. Thank you so much, Dr. Shivanand.
Thank you, madam. Thank you.
Our next presenter will be Dr. Jagdish Menon. He will talk about trauma to the bony pelvis. Dr. Jagdish is professor of orthopedics, and he is the course of orthopedics at JIPMER Pondicherry, and he is the course director for ATLS. Thank you very much, Dr. Jagdish, for helping us by presenting on trauma to the bony pelvis. Thank you again.
Thank you, ma'am. It's a privilege to be here. And I understand most of the audience is about students. So what I have done is I would give just an overview of trauma to the bony pelvis and focus on the acute management rather than the difficult cases that we have managed. So why are we interested in pelvic fractures? We are interested because of the high rates of mortality that is associated with pelvic fractures. And the mortality in pelvic fractures is essentially due to hemorrhage and the associated traumatic injuries. So if a patient has a pelvic fracture, severe pelvic injury with a traumatic brain injury, the odds ratio of the patient succumbing is close to 5. So he has a 5 times greater risk of dying when he has this combination. Similarly, if you see the risk with severe abdominal trauma, it is similar. So whenever there is an associated injury with the pelvis, then you find that the mortality rates do go up. Similarly, if about 15% of the pelvic fractures present with shock, and the mere reason that they have arrived with shock pushes up the mortality to about 2 times. And we also know that in an open pelvic fracture, we almost lose 1 in 3 patients, about 30% mortality we have. So this is the reason why a pelvic fracture is a focus of great debate and great learning. Just one slide on the terminology and the semantics rather than anything. When we talk about instability in the pelvic fracture, we are actually speaking about the hemodynamic. From the orthopedic point of view, obviously there is a mechanical, anatomical instability, but we are essentially focusing on hemodynamic instability, which manifests as low systolic BP. Even if the systolic BP can be bumped up, it requires massive transfusions. It requires some inotropic support. We are going to focus on this. We know that in the unstable pelvis, it is important to find out, in the unstable patient rather, it is important to find out whether the pelvis is the source of bleed. And for this, we have the ATLS protocol, which includes clinical examination and an adjunct called the pelvic X-ray. The clinical diagnosis of pelvic trauma, you should think of pelvic trauma in any patient that complains of pelvic pain. That is a patient who's likely to have pelvic trauma. We also believe that the patient would have a pelvic fracture if any patient comes with shock or altered consciousness. All high energy trauma are believed to have pelvic fractures unless ruled out. In the cohort of elderly patients, just a low energy is enough to push the patient towards shock and hemodynamic instability. So in these group of patients, we must have a high index of suspicion. Much has been said about the clinical diagnosis of pelvic trauma by using limb length instability, by using tests like distraction and compression, but we always find that they are A, unreliable, B, and they are likely to cause further harm. So rather than going for an exact diagnosis here, it is good to detect that the patient has a pelvic injury. What is the role of the X-ray? All hemodynamically unstable patients, any patient which requires an urgent intervention, even if he's hemodynamically borderline, like an intubation or a chest tube, must get a pelvic X-ray on arrival. For others, it could wait. Probably a CT with contrast is a better idea when they are stable. We know that the pelvis is a ring bounded down by strong ligaments, so it requires very high energy to disrupt this ring. And because of the shape, we draw reassurance from some certain markers, which is the pelvic ring, the obturator foramen, the Shenton's line, which tells us about the hip joint, the pubis symphysis, and the distances in the sacroiliac joint. So this gives us an idea whether the pelvis is injured or not. There is this bangle theory, which says that a ring has to be broken in two places for it to displace. So if you cut a ring in one place, it would still remain a ring. So when you see that the ring is disrupted, it means that there are two injuries. This is very important to know, because sometimes you would find just open book fractures and you would believe that the posterior part is intact. Rest assured, there would be a sacroiliac injury. These are just examples of an open book. If the pelvis ring is distorted, there has to be a mandatory posterior injury. So you can see the SI joint opening in the first X-ray. The other is something which we call the lateral compression type of fracture. Again, you can find there is an anterior injury on the left side, and there is a posterior injury, sacroiliac injury on the right side. So remember this, what we call the bangle principle. What is the role of E-FAST? Essentially to find out if there are any other bleeds. You could use it to find out whether there is a diastasis of the pubic symphysis. Typically, anything more than 25 mm is significant. Now, coming to bleeding from the pelvic fracture, there are essentially four sources: the fracture, venous bleed, arterial bleed, and bleeding from visceral injuries. Now, if the bleeding for all this combined is very severe, the patient goes into hemodynamic unstable state. The ATLS tells us how to manage this, replenish the lost volume, and control bleeding. So in the next few slides, we're going to talk about the definite bleeding control rather than the replenishment of volume. Nothing about the massive transfusion protocol, the fluid management, but rather how do you control bleeding locally? Just like there are 4 sources of bleeding, there are also nearly 4 sources of reduction of bleeding, or helps to reduce bleeding. And these are pelvic binders, essentially internal fractures. This has got stuff. Yeah. Essentially internal fixation, angiographic embolization, and pelvic tamponade. What is now coming up is endovascular occlusion of the aorta. So what about the pelvic sling? The pelvic binder is probably the best initial device to apply, especially in pre-hospital, or even the patient comes into ED for the first time. They are commercially available binders, which every ED has. And if there is a shortage or something missing, we can always improvise using hospital equipment. What does a binder do? It is believed that it reduces the volume, but we all understand that the volume of the pelvis, even without a fracture, is so much that it can contain significant blood volume. So it is believed rather than reduction, it stabilizes the fracture fragments and then reduces the bleeding. Very often we find that the pelvis binder is not in the right place, but sometimes above the abdomen. This is counterproductive and actually increases the bleeding. Since it stabilizes fracture fragments, you can deploy the pelvic binder in all fractures, not only to close the open book fractures. So this is what a pelvic binder can do. Just a pelvic binder can do. Just close the fracture and close the diastasis and make it stable. It is not without complications. They are not supposed to be put more than 24 hours. If you want them for more than 24 hours, it is better to replace them with external fixation. Skin necrosis and pressure ulcers are a usual accompaniment for prolonged pelvic binders. Now coming to external fixation. You have 2 types here again. One is the traditional frame. What the photograph shows is pins into the iliac crest, close the pelvis, and then connect them to the rods. This is the traditional external fixation, quick to deploy, just requires 1 or 2 pins in the iliac crest, and then you close it and clamp it over rods. This stabilizes the pelvis. But you have to remember that if the posterior part of the pelvis, the SI joints are open, as you close the pelvis anteriorly, what would happen is they open posteriorly. And what you do is by putting a fixator, you actually increase the instability. The fixator that is used when there is posterior instability is called a GANS or a C-clamp. These are very precious resources and not found in every hospital, but these can do wonders if there is a posterior, an SI joint disruption. Where the X-fix goes over the binder, you can leave the fixator on as long as the fracture requires it. You can't do that with a binder. And then obviously when there are open wounds, laparotomies and colostomies, you cannot use the binder, and that is where the X-fix finds preference. So if you do this, if you put a binder or put the fixator and the patient becomes hemodynamically stable, you can always go back and do a definitive fixation for the pelvic ring in a less emergent fixation. But the problem starts when then, in spite of aggressive resuscitation, in spite of excluding other bleeding injuries, and in spite of pelvic stabilization, the patient remains unstable. Here you have 2 options: angiographic embolization and pelvic packing. I think Dr. Shivanand very elegantly explained the uses of pelvic embolization. So pelvic packing is based on the premise that 90% of the bleeding that occurs in a pelvic fracture comes from the presacral venous plexus and retroperitoneum. Also, when there is an arterial bleed, it is almost sure that there is also a venous bleed. This can be done rapidly, especially in expert hands, and usually follows an external fixator to the pelvis. And it has a great role. When you don't have an angiographic service, this is the only option that you have. The rates for embolization after packing is actually about 13 to 20%. So you might repeat a secondary procedure to stop bleeding. Transperitoneal, retroperitoneal routes, they work on the tamponade effect, especially if the source of bleeding is unknown. You require another surgery to remove the padding. They may not control arterial bleeding, and they might even compromise further incision that may use to be surgically stabilize the bony pelvis. Angiographic embolization has already been talked about. The arterial bleeds in pelvic fractures are quite less. They are 10%. But this 10% actually forms a large group of the people who are persistently hypotensive. In unstable patients, non-selective internal iliac embolization is used, where if they are stable, selective angioembolization can be used. They have their own issues. Obviously, the first thing is the availability, the delay that it might take to shift the patient to an angiography suite, and the complications that might occur. So that's an internal iliac embolization, which stops the bleeding unilateral in this particular case, which was taken up in our hospital. There is a great debate which is better, pelvic packing or embolization. Most of it relates to the time. So taking a patient to OT where there is a direct surgical care pathway often is faster and you get good responses. So most of the studies put pelvic packing better at a better rate in terms of patient saving and the amount of transfusions that is required. Peritoneal packing appears to be better. But the take-home message is this, that there is no real one thing that is better, and everything depends on what surgical pathway you have at your institution. And you must develop an institutional protocol, taking full cooperation of the specialists that are involved, the interventional radiologist. In our institution, we usually call the cardiologist because the interventional radiology is a new department there. And we always find the cardiologist is quick out of the blocks. He's quick to respond. So we tend to call the cardiologist there. Some literature, recent literature about endovascular occlusion of the aorta. We don't have any experience here in JIPMER. Probably it's a bridge to definite therapy for non-responders or people who are in extremis. Probably the zone through which is the infrarenal can prevent visceral ischemia. Again, a gray area for us. There are a lot of questions that need answering. We know that open pelvic fractures have a very severe mortality. You're likely to lose 1 in 2. Patients with open pelvic fractures, they require emergency debridement and stabilization, and more often than not, a diverting colostomy. Do you really do internal fixation? If a laparotomy has been completed and the patient is relatively stable, through the same wound, actually, you can plate the pubis, and an iliosacral screw doesn't take much time nowadays with the image. Once the patient is hemodynamically stable, contrast CT can exclude bleeds. We also take a 3D reconstruction, which makes the surgical job of fixing the pelvis easier. Searching for other injuries, especially the urethral injuries, can go on. Similarly, any visceral injuries can also be investigated upon. Last slide. What would be like in the future? Probably this is the wish list. Maybe CT scanners inside theaters and quick response CT scanners in the ED. Angiography suite round the clock, which is accessible, where we can deploy quickly. And the use of computer navigated systems, which would help in minimally invasive pathways for bony fixation. The last slide is still this, that you really need to focus on your institute and develop a protocol which can help save patients. Thank you very much.
Thank you, Dr. Jagdish. I learned 2 things today. That E-fast you can use for symphysis distraction. I didn't know this, number 1. And then this insistence on to develop an institutional protocol is very important. I want to stress on the PGs, because all the time we think we will get the ideal trauma setup and we don't do it. There are enough cases, enough resources, and somehow the protocols are missing and things go haywire. I'm glad you emphasized on that. Thank you very much, Dr. Jagdish, for joining us. And that was very, very informative. And if anybody else has a question, please go ahead. Dr. Jagdish will be happy to answer it. I think there are no questions. I'll move on to my presentation. Thank you again, Dr. Jagdish.
Thank you, ma'am. Thank you again.
Is my screen visible?
Yes, ma'am.
Joseph, 1 second. I'm not able to get it into the slideshow. Is it in the slideshow now?
No, ma'am, it is not.
Oh, it isn't. For me, it is showing slideshow.
You can just do it again, ma'am.
Coming. Okay, now?
Mm,
No, huh?
not yet, ma'am.
Okay, then I'll stop share and go back. Is it okay now?
Yes, it's okay now.
Okay, shall I carry on? Okay.
Yes, ma'am.
Okay. Thank you all very much. I'm the moderator, but I'll be introducing myself. I'm Professor Angeline, Professor of Surgery from Pondicherry Institute of Medical Sciences, Puducherry, and I've just retired. So this presentation is on injury to the bowel. Is my audio clear?
Yes, ma'am, it's perfect.
Okay, fine. So this is injury to the bowel, and all the clinical photos are from my personal collection. And when we talk about injuries to the bowel, it's a whole big thing. Yeah, it starts from the ligament of Treitz and goes up to the anal verge. So if I'm going to talk about every single centimeter of the bowel, it's not possible. So it's going to be a generic description, and it will not confine to a particular anatomy in the bowel. Let's move on. So traumatic bowel injury is a significant clinical concern. You have to understand the mechanisms, presentations, and management strategies. Now, small bowel injuries are the most common, followed by colonic and then the mesenteric injuries. Now, the exact mechanism, how a bowel gets injured, yesterday Dr. Vignesh had told very well about the exact mechanism of injury, or I think it was Dr. Joseph who had explained very well about the shear, about the compression forces, etc. I'm not going to go into that again. So this is from our own paper to tell you that abdominal injuries had contributed to 10% of mortality. This was all in patients with severe trauma who had died. And if you look closely, the hollow viscous injury rate was quite high when compared to international literature. It was only 1% there, but ours showed up to close 3%. We've tried to find out a reason for this. One, we had less of acceleration and deceleration injuries. There is hardly anybody going high speed except in the highways. So acceleration, deceleration, unlikely. And most of the time it was run over. They meet with an accident and they get run over also. So we had a high incidence of hollow viscous injury, the bowel. Now, the jejunum is the highest. That jejunum and ileum, they are the maximum involved. What I wanted to draw your attention was there can be multiple injuries and they can be associated solid organ. Not only that, Dr. Jagdish had rightly pointed out, there can be major extra-abdominal injuries itself, like in the thorax or in your head injuries. So I have to tell the stage for this is the grading of intestinal injury. I'm not going to go into the details. Now, how do they present? It's the same thing, tenderness, distension. They can have very bad vitals. Physical examination may reveal tachycardia. That is tachycardia, sorry, it's not bradycardia. There can be lap belt marks and there can be ecchymosis. Now, what happens when trauma textbooks tell you, they just tell you, yes, he comes with tachycardia, this, that. No. In ground situation, you will find all patients in medicine, whether it is fracture pelvis or traumatic bowel injury or a raised intracranial tension because of a tumor, they will all come in a spectrum. So in a bowel injury, if I were to put them in a spectrum, this is a chap who walks in with a cell phone. He's had a gastric perforation which has closed up. 1 week ago, he had hit himself against a cycle handlebar. He walks into the OPD saying abdominal pain. And then you palpate, there is not much finding. You do an ultrasound, you found a collection, and then you go to the logistical other investigations and you label him as a walled-off gastric perforation injury due to trauma. But you see, he's sitting on his mobile. These are the very small mobiles which used to be there 16 years ago. This is from GH. Or you can find patients sick and in early shock. Or you can have evisceration and all bowel hanging out. Or there can be patients in extremis itself, almost in cardiac arrest. Or when they reach you, they are in arrest. I hope you are able to see the evisceration picture. Joseph, can you make out that last picture? Hello?
Yes, ma'am, it's clear.
Yeah, because I can't see. It is getting
Yeah,
stuck
it is
under
clear.
that. Okay, fine.
Yeah.
So they can present in the extremis. That's why they have even gone outside the red zone. Now, how do they show up? This is very important. Suppose you're doing primary survey to a patient, suspected bowel injury. We are not talking about primary survey in a polytrauma. We are talking about primary survey, and we want to keep a very theoretical situation and saying only isolated bowel injury. Your ABCD may be almost normal, just maybe if you're seeing him within a couple of hours. Is ABCD just for some mild tachycardia? You may not find anything in the vitals, but you'll find abdominal tenderness, hopefully. But what if they were to show up 24 or 48 hours later for whatever reason? You will find the main problem will be in C and in B. In the E, you might find a stab, or you might even find an impaled object. You might find an impaled object even in the first instance. So as I told you, some of them can even come in extremis. Now the seat belt, yes, it's important. But what about our situation? When there is a seat belt injury, there is a 10-fold increase of a bowel injury. That you have to keep in mind. Don't dismiss them off because they did not throw vital sign disruptions. They did not have clinical findings. This was not a seat belt injury, but something similar in mechanism. The Sari Palau had almost caused a seat belt sign on this lady. She was working in a sugarcane factory. And you can see this very faint seat belt. It may not necessarily be the exact seat belt, diagonal and the lap seat belt, but you definitely know there is a faint ecchymosis there. So we were very sure, irrespective of the findings, we are going to be very careful with her. And ultrasound was negative, and we went ahead and did a CT, and then we posted her, and you found multiple serosal patches there. Now, about the chance type, there is a 2 to 3%. You can see L1 and L2 and even L3 can get disrupted. When they get disrupted, you know, enough force has traversed the abdominal cavity and you're likely to find a bowel injury. So when you have this seatbelt sign or a chance fracture, you did not have clinical signs, please go and examine them again. One thing, very reassuring, a bowel injury will definitely show itself up within 48 hours. So you do a serial examination and within 48 hours, you can almost clear them off if you feel that there are absolutely no deteriorating signs and symptoms. So what about the investigations that you have? You have various investigations. And if you look at it, they have the advantages, disadvantages, particular indications, etc. Now, we will not go into the details. You know that the CT will have high specificity for your bowel injuries, not all the time. In fact, if you look at this, sometimes your DPL itself will overscore the CT. I'll come to it again. Somehow the DPL does not get its due. In particular scenarios, it is very, very helpful. I'll go into one of these scenarios. So what are the important CT findings is your hemoperitoneum or your hematoma. Sometimes the bowel wall can be thickened and other things. But there is a negative rate, 15% negative rate is there. What do you do? Scoring systems have come up to bring down this negative rate. We are not going to go into those details now. Now, as I told you, so non-diagnostic imaging, the only thing you have is your serial abdominal examination. Actually, there is a very big weapon. You can easily use it, even in resource pumped up situations. And one thing, rigid hierarchy in investigations may not be appropriate at times. This is not like malignancy, that you do a PET scan, you have a doubt and come back to an ultrasound. No, it doesn't work like that in trauma. Why? I'll tell you. One patient X, CT normal, abdominal findings persisted. We went ahead and did a DPL, and we found a transverse cut to the mesentery, and the whole bowel had gone gangrenous. We picked up WBCs. In fact, the fluid itself was foul smelling. Now, what happens in transverse mesenteric tears? Number one, there will be no peritoneal signs because it has not yet perforated. So that is why you don't pick them up easily. The gangrene bowel will be slowly going stealthily inside, and you might only pick it up on your clinical examination and deterioration of your vitals. This can be missed on your initial CT. Yeah, what will happen? Because there is no perforation, peritonitis, findings will not be florid in the abdomen, and these can very stealthily move into your multiple organ dysfunction. This is another patient. Oh, it's the same. Okay. Now, when your initial CT is negative, but your clinical findings are very, very representative, please go ahead and repeat the CT. You'll find free gas. This is another patient, had free fluid on the abdomen, but somehow in the ultrasound, we more or less knew that there is no obvious solid organ injury, and that free fluid is not very much. So probably not bleeding much. So what did we do? We made her sit up and take an X-ray chest. Here it is lying down, so you will miss. But this, obviously, you have to rule out a cervical injury clinically, or you've done bedside X-rays and ruled it out. You can make her sit up with some guidance, and you got free gas. Now you can post this patient for a laparotomy with very minimal abdominal findings. Now to go and convince somebody this patient needs a laparotomy because I want to have a look, that isn't buy nowadays much. Some people do need something objective to even your anesthetist or the relatives or your own juniors will not be convinced that you just want to open every abdomen and see. So this is our study again. So when your CT is negative, kindly repeat. Number two, the elderly were always presenting late. So always be more careful with them. Be more liberal in repeating of their CTs. This is one of our studies only. We realized that the elderly population somehow was presenting late with the abdominal findings. So what about preoperative broad spectrum, which is mostly like your elective surgery? Of course, there is an infection there, obvious peritonitis. You will continue up to the clinical resolution. So what do? Initial resuscitation, focus, surgical interventions. You have repair, primary repair, resection, or even damage control. Damage control has a big role in solid organ. How about damage control in intestinal injuries? We'll come to it. Post-operative care is equally important. Not only that, always monitor for complications. Don't wait them to throw florid findings of complications. Be there. Keep looking for those complications. If they are there, you will find them early on. Now, intra-op, always look at both sides of the bowel and look at the whole length till you make your decision. Don't be in a hurry and close the first perforation you see. I know enough students will be seeing this presentation, so this is mainly for them. This is a video. And get your assistants. They will be bringing 2 eyes more into your field at 2 o'clock in the night. When you're 50, 60, trying to look at it through your bifocal, get your assistants into the picture. They are too happy to look at the perforation and point it out to you. So don't hesitate. You must know when to use your juniors. You must know when to call your senior for help. Okay. Now, what about suturing? Whether hand suturing or staplers? 4 decades of suturing in the surgical practice, whether acute or elective, not necessarily trauma, has shown no difference between staplers and suture lines. But by and large, staplers will not be possible because invariably your bowel will be edematous. It will not be prepared like your elective bowel. Sometimes you can exteriorize the bowel segments. If you feel your anastomosis is going to break down, better to exteriorize. Handling this fluid and effluent outside, either it is the excoriation or the electrolyte balance or the fluid balance or the nutritional loss, is much easier than handling a peritonitis because of your anastomotic leak. Now, previously, they used to wait for bowel function with either asking patient whether they pass flaters or stool or with your bowel sounds, but now the trend is more towards early feeding. What about, yes, from the minor surgical wound, they can have major problems. Deep surgical infections, burst abdomen, intra-abdominal abscess, fecal fistula, other major systems may be failing, like your lung and kidneys. There can be short bowel because you would have resected quite a bit. And complications can occur because of your intervention itself. If you have not put your feeding tubes properly, they can have issues. If you have not done your central vein, you have not taken precautions, or you have not picked up complications, they can bring in their own complications and push the patient downhill. This is also from our paper. If you see, I'll just show them. Those who were operated 48 to 72 hours, whatever is the reason, you find there is a huge leap in the complication rate. So any delay is in Oliviscus injury is a recipe for complications. And if the complications are mounting, if your morbidity is so mounting, it may ultimately lead to a mortality. So as I told you, it can be from wound infection to a burst abdomen or a totally disrupted bowel. So now see this patient we have done, he has come to us 72 hours later, been treated at multiple institutes or rather nursing homes as non-operative management. Once the patient is very sick, they know he is very sick for whatever reason, and then they transfer to apex centers. You can see he is very sick. You can see the tachycardia and all that. And obviously, we did not close the abdomen because we knew he is going to break down. If he breaks down, let him break down here rather than inside his abdomen. So you see, we have done a laparostomy because we were 100% sure his anastomosis is going to leak. And you can see this disrupted bowel here. Now, coming to damage control in bowel injury, not much of support. Nobody talks about it, and it is not popular at all. If at least bring it out as exteriorization if you feel anastomosis, primary anastomosis is unwise. Now, I want to tell you one particular incident. This patient was a top polytrauma, abdominal findings and CT for hollow viscous injury. On opening, there was a complete transection and no peritoneal contamination at all. You can see the peritoneum is pristine, but it was completely transected. Now, there's a physiology behind it. Certain intestinal injuries can get transected without spillover into the peritoneum because of severe smooth muscle spasm, because I went and read it. After we did the laparotomy, they went in and did the limb saving procedure by fixation and all that. Dr. Jagdish will know more. The orthopedicians came and handled the limb because this limb was borderline threatened. Now, after that, I went and checked the literature. I was posing myself questions. Now, did we have to do this laparotomy? Obviously, when I'm doing the laparotomy, you cannot expect the orthopedicians to be handling this simultaneously. We have taken up minimum 2 hours here. Now, did we do the right thing? Could this have waited, especially when there is no peritoneal contamination? This information was even available to me in the CT. There was no free fluid, but definitely there was pneumoperitoneum. I went and read, and what did I find? Yes, there was case reports, and people started telling, is urgent surgery itself necessary? There is not enough evidence to make recognition, to make recommendations. But this question has also popped up as early as 1999. After that, I did not find any reference after that. So could it have been the other way around? You do the limb saving and then you open the abdomen. Anyway, we cannot make recommendations based on a single case. It was left for discussion and nobody was able to give an answer. But it's the food for thought. It's not moving. I'll come back again. Yeah. Now, as I told you, your CT scan can have 15% negative rate even after repeating. What can we do? We have brought in this AI now. AI is very popular now. It's trying to make its head everywhere. At least when you do research, literature research, you'll find it. They have developed deep learning models, but all said and done, AI has not come much into clinical decision making. Maximum it will be there for organizational work or maybe scribes, like your notes it can generate. Even then, it has not come much into clinical workflows. There are a lot of ethical issues regarding deployment of AI in real clinical scenarios. We will not go into it. It's just a food for thought so that students can go and read much more about AI. Well, what is the conclusion? Yes, your pre-hospital care matters, but in a place like India, yes, you may not find. But one thing, refer patients early on. Don't think you can handle non-operative management. You can handle non-operative management only when you know I can do a laparotomy on this patient. That mostly some centers don't do. Some smaller hospitals don't do that. They think non-operative management is sort of, just admitting and keeping him there. That is where the problem comes. Repeat CT when you have high suspicion. Don't decry DPL. They have a role there. And any surgeon will not be, when he can do a laparotomy, he's not going to worry about the complications of DPL. And as I told you, institutional pathways are very important. We cannot all the time go aping the centers of excellence. Institutional protocols in high volume centers, they cannot all the time go aping. It doesn't hurt to go and ape them, provided it is possible. As Dr. Jagdish mentioned, very important to have institutional protocols. And as I would thank you all again, this is an embroidery. What I wanted to, even in the embroidery, somebody has been so meticulous and shown the tinea coli. That's what I wanted to bring this. Thank you all very much. Any questions? Any questions? If no questions, shall I move on to the next one? Is this visible now, Joseph? 1 second. Is it visible?
I
Is
don't
it
think so,
visible?
ma'am. No, ma'am, I don't think so.
Well, then I'll come out, Joseph.
Jagdish here, ma'am.
Jagdish, shall I come out and go again?
You could try that, ma'am.
1 second. 1 second. Is this the slide view is visible?
Yes, ma'am, it's visible.
It's visible now. Shall I go on? Shall I start?
Yes, ma'am.
Okay, fine. Again, ANGELINE here. I'm not going to introduce myself. Today, we are going to talk about pitfalls in any trauma for that matter, but this is specifically abdominal trauma. You must understand in trauma, every minute counts. And every sand particle matters. That is your physiology. They will keep building up very silently, but rapidly and blow up on your face. So when I talked about pitfalls, the first thing everybody will think is the pitfalls of non-operative management and its risk. Okay, everybody will talk about the non-operative management and its risk, but it is much more than that. Have a look. The pitfalls can be right from the time of trauma to your intraoperative to the discharge. I don't know why the photo is not there, a patient getting discharged. The pitfalls can continue even inside his house. You have put a feeding jejunostomy tube and sent him home. That can get dislodged. So you must understand pitfalls are not just NOMs related. They can start off from here. You will understand in a minute how pre-hospital will matter. Okay, so this is the patient who's got discharged. This is just metaphorical. He's all smiles. When he goes home, he can have still problems. Whether it's non-operative management or an operative management, keep it in mind that they are going to have pitfalls there also. So in the pre-hospital care, about the time taken to reach you, about the multiple referrals that they will be having, stabilize impaled foreign bodies, and there's something known as BTLS access. We'll come to all this later. Coming to examination, always look for tenderness away from the stab. At the point of stab, you will find tenderness next 5 centimeters, but always look far off. I'll show a video. Thoracojunctional penetrating injuries, yes, very important. Penetrating wounds in the perineum. Investigations, please send with the full bladder. Don't drain it. In your primary survey, you will not be seeing the urinary output. That is hourly output. This is what was in his bladder already. It did not help you in the resuscitation. So send him with the full bladder. Get the ultrasound if he has to move out, and then drain the bladder. Number one. You may need to repeat fast, and always unsupervised intra-hospital transfer is a big issue. I understand centers which have a mobile CT and everything, it's okay for them. But if you're going to transfer, please take an escort. Not that an escort can stop bleeding. At least they will make sure that this fragile physiology is not actually manhandled during transfer into the CT gurney. As I told you, gold standard is a serial examination, and there should be no hierarchy in your investigations. Now, when it comes to altered consciousness, they may not complain of pain, but tenderness you will elicit. Very many juniors will come and say, sir, his GCS is 8, so I could not elicit tenderness. No, they are wrong. They could not elicit pain in the history. Tenderness will be there. Keep this in mind. So in your pre-op, take stoma consent. Intra-op, make sure lights. The lights is the biggest issue in your trauma abdomen. You'll be operating at 2 o'clock in the night. Junior, most person will be operating most of the time. Your lights need to go into all quadrants, and that no automatic light will do. You need somebody there to rotate the light as you move into the quadrants. Very important, especially pelvis. You won't be able to see. The right upper and left upper also you won't be able to see. So be nice, tell the OT staff, please don't leave me till I tell you to go. And most of them listen. You need their help. Pads, very important. Tell staff you might need many pads. Keep them radio tagged. Suction bottles, always keep 2 with you. Whether it is peritonitis or hemoperitoneum, keep 2 bottles. Otherwise, what happens? 1 bottle will fill up in no time, 1 liter. It will be a mess in the theater. Number 2, you will lose count of the amount that has gone into the bottle. And then they'll go and bring the other one, or they will wash this. But if you tell them in the beginning only, I want 2 bottles, they always oblige. Now, as I told you, intra-op, look at both sides. People have missed even on a laparotomy. That is why please tell your assistants, if you're elderly, please look for further perforation. If not, for the interest of the patient, your juniors will be looking for a perforation just to tease you. They'll say, you missed this. There is one there. All that helps in patient outcome actually. So you look at the pad and instrument count. Now, preemptive complications. Look for ileus. How will you look for collection and leak? How? By ileus, by subtle tachycardias. Don't wait for them to become manifest. All the time preemptively look for complications. Sometimes specialties will push you to do a laparotomy, a BK amputation guy with a very minimal free fluid. I know Dr. Jagdish is going to murder me for this, but this sometimes can happen, and you'll end up opening the abdomen. One more important thing, any trauma fatality, please check on postmortem and talk to the forensic. It helps a lot. As a trauma surgeon, you need not necessarily go and see the postmortem. It may not be logistically possible. But in fatalities, make sure you go and see the postmortem report or liaise with them or even go there yourself. Now, as I told you, your pitfall can start in the pre-hospital phase. This is our own study done in GH. This patient, blunt injury to the abdomen or other blunt trauma, he takes more than 3 hours to come to us. But you see the ones with the knife sticking out and the wooden rod sticking out. Within an hour, they are with you. Nobody keeps them, including in the road. They will be packed off very quickly. So the pitfall is starting there. In the pre-operative setup itself, they will reach very early to you. These will be coming late. And always stabilize impaled foreign objects. Like this, please put this figure cross and stabilize so that it does not cause more harm. Similarly, this was another iron rod which had pierced the popliteal fossa, gone up to the abdomen and lodged inside the, very close to the diaphragm, torn the colon. Actually, this was a little obese lady. She was walking on her balcony, a half-built balcony, and she fell onto the centering near Annamalai. This was in PIMS, not my case, but colleague's case. So always you need to remove this. This can't be going during transfer or into your CT also. So you need some sort of ease to transfer the patient. That is known as access. So you will cut off the protruding ends. Now, when you cut off the protruding ends, you will be probably using some semi-powered drills that will heat up these rods. That will cause more harm to your muscle and other tissues in the limb. So always keep pouring saline at the point of cutting, like the way you use a giggly saw. That is not to transfer the heat, that is for ease of, that is to lessen the friction. But here you keep pouring saline to reduce the heat. And always look at the nearby cavities, like your abdomen problem, look into the thorax. So as I told you, you use an appropriate tool and you will need sedation to remove this. You see, we have removed it and generated heat to be neutralized. One more thing about ballistics. This a patient who comes, he's saying 5 centimeter knife. His relatives also, or the bystanders, just 5 centimeter. Yes, we believe them. It is 5 centimeter. But if you look at it, it's going to pierce the abdomen. Abdomen is a very, very elastic thing. And number two, he's going to fall over the knife. So you can find the knife with a 5 centimeter, like the accordion that you play, things can pleat over themselves and go and hit against the sharp end. And this 5 centimeter can even touch the great vessels across the spine. So your blade size should not be, you should not be complacent saying the blade size is only 5 centimeter. Now coming to other cavities, this patient, when they have a penetrating injury to the abdomen, always look into the thorax clinically and imaging. As Dr. Shivanand had said, any CT is a torso CT. It's neither chest nor abdomen. It's a torso CT. Have a look. This patient actually had come with a stab to the epigastrium. And in our primary survey, he came walking, no issues, not that he was very sick. And when we did a primary survey, we realized there is loss of air entry. So what did the X-ray chest show? Severe hemothorax. In fact, that hemothorax has become a pyothorax now. It's about 72 hours old. So innocuous looking abdominal injury. Don't only concentrate here. Move into the next cavity. Similarly, thoracic stab. Yes, you will definitely evaluate the thorax completely, but look into the abdomen also. See, this is a patient with the stab here, almost just lower to the nipple. Absolutely, the thorax was pristine. He had problems only in the abdomen. You see, huge retroperitoneal hematoma, almost going into the leaves of the mesentery. So what I want to tell, when there is a stab in one zone, especially in junctional zones between the thorax and the abdomen, look into the other cavity also. So thoracic, look abdomen, abdomen, look chest. One more thing, this is a bulgur to the perineum. Now, don't just look at this injury. There is something known as a toss that can cause more harm. This fellow actually had a ruptured spleen. This is the last of his problem. Only thing is it's very visual. And everybody going saying bulgur, bulgur. But the main problem was a shattered spleen. That you will pick up if you're aware that he can be tossed. And number two, there can be abdominal injuries. And actually you will do your ATLS accordingly and pick it up. So coming to tenderness, I told you pitfalls. Coming to tenderness in the elderly, have a look. This lady again had a bulgur, not bulgur, the bull buttered on her abdomen. You see, hardly any tenderness. You have to really press and get it out of her. There is so much of fat. It's, see, very deep, she is having tenderness. Now, without a clinical finding, I cannot be indiscriminately investigating or running with her to laparotomy. Number two, look, especially in obese and the elderly. Now, look at this. As I told you, stab injuries, this put a gauze here, there is a stab. You will find tenderness here, but you need to go away and check whether there is tenderness. With this tenderness, you cannot assume there is an intraperitoneal injury, nor can you run with this patient into the OR. So let's have a look at this video. Definitely tenderness is there. There is no doubt. You can see him wincing. I'm moving away. See, when I moved away, I've come back again to the stab. You can see it second time if you want. Maybe the video was too quick. See, we are not professional photographers. We'll go carrying the mobile on the right hand and using left hand to palpate and trying to capture these photos so that our students get to know these things. I just cannot tell tenderness away from the site unless I show it to them. Okay, fine. Okay, coming to distraction, distracting injuries. See the distractions. These are very, very obvious. Similarly, this hand injury. Now, sometimes this distraction will be picked up by your own colleagues and they'll be harping on that. It's a multidisciplinary team. Your own surgery colleagues will be sitting on the distraction part. And if you have any doubt, please use image. Fine. So this is what I wanted to tell. Next. Sometimes your abdominal injury will get pushed down lower in the hierarchy. One, because of distraction. Number two, you won't be able to clinically assess the abdomens. Either there is altered consciousness or sometimes your abdomen will not be available for palpation itself. Where can you put your hand and find out something? This is a fixator. So be liberal in using imaging. This is very important. You can use your ultrasound itself. It will be compatible with all these rods. As I told you, no hierarchy. Kindly go ahead and do a DPL. Also, this has come in the bowel injury. One more thing, intra-op, when you suspect hemoperitoneum or a bowel rupture, everybody, yes, you need to put an incision from the xiphisternum to the symphysis. But when you open the peritoneum, keep a small nick, put a suction there first. Otherwise, the whole thing is opened up. The blood is all over the place. You will lose count of how much blood or how much peritoneal contamination was there. The OT is a mess. The staff will try to find comfort zones in that mess. There is a whole lot of hypothermia. All this fluid will go and stick into the drapes. There is a whole lot of hypothermia. And most important, you will not be able to tell the amount of contamination and the blood loss. So always open up a small portion. Try to suck it out. It won't take more than 2 or 3 minutes. That doesn't matter. And then you open up both planes, both sides, up and down, and then do the rest of the trauma lab. As I told you, look at both sides, and then you look at the instrument count. Instrument counts and pad counts are likely to have issues in emergency surgery, more in trauma. Because most of us, you can't help it. You'll be going unprepared. Staff will be unprepared. Always be careful about these things because they are sentinel events at the end of it. As I told you, this is appearing just like this, but then if you see, it's a through and through injury. So call for help. When you have an issue, call for help is available. There's something known as a negative laparotomy. It can be up to 4%. And there's something known as a non-therapeutic laparotomy, which is 9%. You can accept that because that 9% non-therapeutic laparotomy is to save the 91% who really have an issue. So that is acceptable. By universal standards, it's acceptable to have 4% laparotomy, negative laparotomy, and non-therapeutic is when you're not doing any therapy, they are just some abrasions and serosal tears. That can be up to 9 and negative can be up to 4. Now, as I told you, always have preemptive complications. If your patient is here, you as a surgeon should be sitting here, not with your vitals. But if you sit here, you will pick up when he's traveling along this bad trajectory. The problem is most of us stay where the patient is staying. We don't go look forward. Always go forward and look whether your patient is following you. You're likely to pick up small things. Not small things, you're likely to pick up early things. So keep that in mind. If you have operated, this probably is, it holds good in every surgery, more so in trauma. Move one step further in the spectrum, stand there, see whether your patient is following you. If he does not follow you, you're happy, patient is happy, and you can bless yourself. Now, as I told you, they are man-made anatomical boundaries. Textbooks are compelled to address blunt injury in isolation because they need a fair amount of comprehension. But in ground reality, you can have problems. Like you've done everything properly in the abdomen, but your lungs are slowly going downhill. Keep an eye. Don't outsource that to the physicians. Don't outsource that to the intensive care people. After all, they are your patient. You can take the help, but don't outsource complete that, including diagnosis. They will preemptively look into it. They have other things to do also. Okay, introp, I told you. Sorry. Have a look. Please follow up the postmortem. Network with your forensic medicine colleagues. Patients can teach you even after they are no more. Have a look. This patient has come incident 1 hour ago. PIMS has a lot of that fisherman community, very close by. They keep quarreling with each other. He was stabbed and he was brought within 1 hour. It's a possibility. They can come to your A&E within 1 hour. But he was brought in extremis and he died. This bowel is ruptured and hanging out. Now, we know that this bowel could not have caused the immediate death. He's come within 1 hour. He has a stab here on the right iliac fossa. The right side stab had pierced the IVC. This is the idea of going to checking on the postmortem. Not that you must go to postmortem. This is the idea of checking on the postmortem. One case you see, next time this will be in your mind. You can say no, within 1 hour he couldn't have died. I have personally noted the postmortem reports when you get a next similar case. Now, coming to damage control surgery, we keep talking about it. There needs to be a balance. It's very important that you have a balance. So either you go and do damage control for everybody. So you have not given him a chance of less morbidity. Or you didn't do a damage control on deserving people and you kill them in the process. So there is something, how do you find a balance objectively? There is something known as scorings. We will not go again into the details. So trauma is time sensitive. Okay, trauma is time sensitive. Physiological response may not be uniform across the board. I told you. Patients can present anywhere in the spectrum. As I told you, that chap with the mobile phone and this one with the evascurization who almost went through us into the postmortem room. So what about the skills available in the facility? As I told you, institutional protocols need to improve with each trauma fatality. That is very important. Now, we usually talk about rehab in limb injuries or in head injuries, but when it comes to abdominal trauma, we don't talk about rehab. There is a little role for them. See this patient. He has a tracheostomy there that has to get weaned off. He had a very serious liver injury that has to get weaned off. Not only that, he's not very catatonic. He hardly had muscle strength to breathe on his own. So all those things need a bit of rehab. One more thing. You will be pushed around. So for that, have networking. Very, very important. Your neurosurgeon or radiologist may, however disturbing the imaging report, your only weapon to prevent a negative laparotomy is your clinical findings. Sometimes neurosurgeons, they will find distinction, that will be because of ileus, but they will say there is an abdominal injury. Don't take already sick patients and go and open the abdomen. Why not be at least 90% sure with your imaging, with your clinical findings, with your experience, and avoid it? Whatever it is, your clinical examination always comes in handy. Very important. Sometimes there can be pressure from the ICU, especially for closure of a laparotomy or to delay the enteral feeds or to start parenteral feeds. The dietitian will insist that you start parenteral feeds. Then the ICU doctor also will say start parenteral feeds. Within 72 hours, nothing will happen to his nutrition. Don't be in a hurry because somebody pushed you to do something with which will land up with unwanted, something not indicated is contraindicated in a patient. Especially closure of a laparostomy. Look at this laparostomy. This whole abdomen was outside. This was also a liver injury. So much of edema, we had to keep it out. Invariably, the attenders, patient cannot, poor thing, he is at the mercy. Your ICU staff, because it's such a visually disturbing people who are not initiated to a laparostomy. They will keep insisting to close it. And if you ask them why, they will put the blame on the attenders. They will say, attender told to, it would be better to close. So I know this vicious circle there. We have worked in enough trauma issues. Hold your ground. By going and closing this, don't kill off patients. So as I told you, clinical examination may not be sensitive, but a serial clinical examination can get you there. Now coming to, again, AI. There are some AI applications. One is your trauma care AI. It is mainly, it gets integrated into the electronic health record. There is something for rib fractures and there is something for clinically. This is the only thing which is clinically deployed. This is in the US. In India, there is not much for trauma I have seen. For cardiac arrest, it is employed. That's all in one hospital in Hyderabad. So this is clinically deployed now. So that is about AI. Now in trauma, your leadership skills or rather your soft skills will be put to test, and you can also develop your soft skills like leadership. See this resuscitation going on. You need to be a leader there, and to be a leader, you need to be competent for the level that you are in. Suppose you're a junior resident, you must have that much of competence. You're a senior resident, that much level, a consultant, that much level. They should not be below the competency required of that particular cadre. Communication. Once you're a good leader, automatically communication and the rest will come. So if you really look at it, it is the competency that matters. You have competency, automatically these factors will fall in place and keep networking with the others, the interventional radiologists I just now told you, or your gastroenterologist, or you're doing a definitive repair of the liver injury, which has got a hilar disruption. You might need the surgical gastroenterologist and a whole lot of things. So this is where your teamwork comes, and the teamwork cannot come overnight in this situation. That has to be done many years earlier or many weeks earlier. That teamwork should be in place. So now what has happened? So what has happened? Previously, all abdominal trauma mandatory laparotomy. Now it has started coming to non-operative. Now, even when there is a blush, if you have enough expertise available to sit on the patient, they don't do anything. So this is how the trend is going on in abdominal injury. We are not talking about bowel injury. We are talking about abdominal injury as a whole. So apart from the core clinical works, to strive towards thumbs up from your patients, please do your audit and research also. This is one of our liver patients. He's giving us a thumbs up. And even this master class is towards improving trauma patient care. Now, what has happened? 2 trauma surgeons, they are doing the EFAS, most of them. Do they also have to enter the IR? It's debatable. Thank God Dr. Shivanand is not there. But there is a push to ask them to do some sort of training in IR so that you can do the IR part without, probably overworking the radiologists. This is just in the discussion and probably in pilot projects. So now if this particular presentation, the audience and students have come out with a clear understanding about the possible pitfalls, then injured patients will be real beneficiaries of this presentation. Thank you all very much. I'll be happy to take questions. Any questions? Any questions? Jagdish, any question? Vijay Kumar sir, thank you. You came today.
Nothing, ma'am.
Very much,
lovely
sir.
Presentation completely from experience. So it was education by itself listening to it.
Thank you so much.
Fantastic
Jagdish.
presentation, ma'am. It's all experience, and the presentation dips into what you have done over the years. Very educative.
Thank you so much, Jagdish, and thanks for coming all over today.
Sure, ma'am. Thank you. I got late because of the office work, but then I think
no issues. I understand, Jagdish. I understand, and thank you again very much. Vijay Kumar sir, any question? Vijay Kumar sir, any question?
No, madam. It was a very good lecture, madam.
Thank you very much, sir. Avinash, or I think Pinesh is there. Pinesh?
Yeah.
मैं मीटिंग को लीव कर दूं? हाँ? I will leave the meeting. Okay, then I'll leave the meeting. Thank you all very much. Please do enter the WhatsApp group. It will be very helpful. Thank you again.
मैम मैं लाइव स्ट्रीम बंद कर देता हूँ.
हाँ बंद कर दीजिए.
ठीक है मैम.
हाँ मैं देख रही हूँ, आप बंद कीजिए. Thanks Pinesh, and thank you Professor sir. Thank you very much VK Professor sir.
Welcome ma'am.